All right, it's 12:05. Why don't we go ahead and get started? Marcus, before we get started, is there a way for participants to introduce themselves with webinar or not? Yeah, or can we do that or no?
Yes, we can.
Okay, because it'd be great for us to know who's here and who we're talking to. So first and foremost, I'd like to thank everyone for taking time out of what is a crazy time. As I was articulating earlier, you know, we're in the middle of social realignment. We're in the middle of a pandemic, an economic downturn, school returning, an opioid crisis, a Hep C crisis, and an HIV crisis in the state of West Virginia. But, you know, one of the reasons that we wanted to bring everyone together is to talk a bit about kind of what some of the community education group priorities are, but also to learn about what work you're doing and how, if possible, we can work together to ameliorate some of the challenges that are before us. And so I'm Tony Young. I am the founder and executive director of Community Education Group. We have offices in West Virginia as well as in Washington, D.C. Our areas of focus are Hep elimination, HIV elimination and awareness, the substance use disorder, but particularly right now working in West Virginia on overturning the moratorium on methadone utilization, or the OTP moratorium as it is known. So I'm gonna let folks introduce themselves. And I think, you know, if you could say who you are, where you're from, and we might take a few minutes with this, but I think it's important to know who all is on the call. But also tell us something either that you're working on, that you're grateful for, that you're proud of, but something on the positive bent, all right? I know, dig down deep. I'm sure you've got something. Marcus, you go.
All right, my name is Marcus Hopkins again. I am the policy director for the Community Education Group, and I have been working diligently to expand our advocacy efforts here in the state of West Virginia around reducing silos for substance use disorder, HIV, and viral hepatitis. I'm going to go down the list of attendees as soon as the panelists are done. I'm going to go down the list of attendees alphabetically, and it'll individually activate you to talk, and then we'll go through that. Adrian?
Awesome. Hi, everyone. My name is Adrian Simmons. I am the policy manager for the National Viral Hepatitis Roundtable, also known as NVHR. We are a program of the Hepatitis Education Project, which is a community-based organization in Seattle. But I am in charge of all of our advocacy efforts, so I'm actually physically located in Washington, D.C., the other Washington. I'm glad to be with the group today and talk about some really, really important topics. NVHR is a national coalition of over 500 members, and really we're working together to eliminate viral hepatitis in the United States. So I'm here today to just do a brief intro about elimination efforts across the country, and to hear more about what's happening in West Virginia. So thanks for having me.
What are you grateful for? What are you happy for?
Thank you. What am I grateful for? So what am I happy for? So last night, I actually watched a battle between two of my all-time favorite artists, Monica and Brandy, and sang it to the top of my lungs for 3 hours after a really, really long day. So that's what I'm grateful for today.
Cool beans. Thanks. Anna Banana.
Good morning, everyone. I guess good afternoon in the East Coast. My name is Anna. I am the Health Policy Associate at Southern AIDS Coalition, aka SAC. So at SAC, we're working a lot with all the southern states, implementing the EHE plan. And something that, and I've just started 2 months ago, so I'm getting a hang of things. Something I'm grateful for, that even though we are stuck inside our homes, at least I can go out in nature, ride my bike, go on hikes. I went paddleboarding this weekend, which was really cool. So I'm grateful for being able to enjoy nature.
Good afternoon, everyone. My name is Nicole Elenoff, and I'm a manager on the prevention team at NASDAD. NASDAD works with health departments all across the country, but we also are the capacity building provider for the South. And we also are working closely we're the National Technical Assistance Advisor for the jurisdictions that are working on the End the HIV Epidemic plan. As far as what I'm grateful for the first time in 8 months, I was able to see my family, and really happy and appreciative to have this opportunity. And thank you so much for having us.
Cool beans. Mike?
Yep. Good afternoon, everyone. My name is Mike Weir. I'm a senior manager on NASDAQ's Policy and Legislative Affairs team. So I'm happy to join everyone today and be here with my colleague, Nicole. Something I'm thankful for would be family. I'm down visiting some family now in North Carolina, and so I'm grateful to be able to get away from DC and spend some time with them.
Cool. So Marcus, if we could go ahead and figure out how to introduce who's listening and who's with us, and even if we want to go ahead and populate the screen so we can see people. I always just feel better seeing people for some reason. I don't know why, because maybe I've been in the house for 4 months, so I don't know. Hopefully.
Give me just a few moments. And okay, so attendees can't share video.
Okay.
It's just the panelists. So
right.
give me just a moment.
But they'll be able to join in, right? Because we want them to
yes,
talk.
give me just a moment. Okay, so we're going to start with Isla Akkad, and go ahead.
That's my dog.
Hi, I'm Ayla Achad, and I'm the Executive Director of the Future of Nursing West Virginia. We are partners with a group called INSTA, which is the International Nursing Society on Addictions. And we're participating in an online webinar for nurses, particularly nurses who prescribe, and giving them all kinds of alternatives, as well as educating them to the what they need to know about addiction. I'm grateful for my health and my family, and the fact that the sun is shining today. Thank you.
Okay, Alice and me.
Good morning, I'm Allison Mee. I'm with On Track Anti-Drug Coalitions here in the Eastern Panhandle of West Virginia. And we are focused on preventing substance use disorders in youth up to age 24. And today I'm feeling grateful for all the communication that does work, for this meeting, and also for some emails this morning that I had questions for people and I knew the right person to ask, and they were able to give me some answers. So that was great. Thank you.
Okay, Amanda Morgan.
Hi, I'm Amanda Morgan. I am the HIV-free West Virginia coordinator for Community Education Group, and I am thankful that everybody joined in today to be with us. Looking forward to what everybody has to say about what we're doing in the state.
Okay, Amber Laquana. Go ahead, Amber.
Sorry, I was muted. My apologies. I am working with CEG and media to help tell your story, hopefully, over the course of time. And I'm very thankful for the people doing good work who care about communities and those in the world, especially those who might be challenged at this time. So I'm happy to be here.
Amy Snodgrass.
Hello, can you hear me? I'm good.
Yes.
Okay, I'm Amy Snodgrass. I am project director of a Rural Communities Opioid Response Grant, RECOR, through HRSA, and I'm in Parkersburg, West Virginia. And our counties we have 7 included in our grant, and I'm very thankful. I can't remember who said it, but I ordered a foldable kayak that rolls up to be placed in the back of my seat, and I was able to use it this past weekend for the first time.
All right, Andrew Bell is not in a great place to talk, so he has done his audio introduction in the chat. If you are also not in a great place to speak with audio, please go ahead and introduce yourself in the chat window, as Stacy K has done as well. Next is Bill Clark.
Can you hear me?
Yes, we can.
Hi, I'm Bill Clark. I'm with the Eastern Panhandle Regional Planning and Development Council. We help our communities, our towns, our counties, and our economic development folks do projects, grant applications, all kinds of things, anywhere we're needed. And I'm grateful and thankful. I live thankful, but I'm really thankful for the team we have and the challenges we have and opportunities we have. I think we'll make a dent in them, I believe. And I'm also very happy I'm with my dogs today.
Thank you so much. Katie Coyne?
Can you hear me?
Yep. Yes, we can.
Hi, my name is Katie Coyne. I am the health reporter at the Charleston Gazette-Mail. I've been looking whenever I have time. I'm busy just like the rest of you guys, but at HIV and hepatitis for the last few years. Specifically right now, I'm kind of working and investigating a little bit about the less prevalent costs of COVID-19 and how it's taken resources away from responding to different things like HIV and hepatitis and the opioid epidemic. I, similarly to steal someone else's, am grateful I bought an inflatable kayak recently and was able to take it out last weekend. So it's good here in Charleston.
Thank you so much. Car Olean?
Can you hear me?
Yep. Yes, we can.
All right, I'm Carl Olean. I'm the CEO of Enact Community Action Agency here in Charleston, West Virginia. We're one of 16 community action agencies in the state of West Virginia, and we handle 5 counties, those being Kanawha, Putnam, Clay, Fayette, and Boone. We strive to assist those at the poverty level. Actually, we strive to try to eliminate poverty. One way of doing that is obviously through education, and that was one of the reasons why I was very interested in being a stakeholder in this session. And also, I'm very happy for my family and with everything going on, as Tony has mentioned. These are very difficult times, and I'm hoping everyone's taking care and staying safe.
Thanks, Carl.
All right, Carl, I'm going to go ahead and mute you. Okay, Chess Yellett.
Chess?
Thought that would happen automatically. Yeah, I'm Chess Yellett from Shepherdstown. I'm a family doctor. I've been treating addictions for about 30 years. And what I'm incredibly grateful for is that since 2007, I've never had a patient die of an overdose.
That's fantastic. Thank you so much. Okay, Diane Collison.
Hi, my name is Diane Collison. I am the director of the Fayette County Family Resource Network. We are a state-funded grant to provide indirect services to the residents of our county. And I am thankful during this time that I get to spend more time with my children.
Thank you. Okay, Douglas Anderson.
Okay, can you hear me?
Yes, I can.
Great. Doug Anderson, I'm the chairman of the Family Resource Network of the Panhandle and the Health and Human Services Collaborative. I'm chairman of the Health Work Group. We work to integrate community and social services systems. One of the areas that we're pretty proud of starting to work, and hopefully the momentum will continue, and more than happy to share the white paper, but it's a comprehensive white paper on sustaining telehealth here in West Virginia. And the other, I'm grateful for the rain. I like the sunshine, but there hasn't been enough rain for quite some time, so I'm glad for the rain. That's it.
Thank you so much.
Thanks. All right. If we can, I want to try and get to everyone, but I know that our NASDAQ colleagues have a hard stop at 1, so I'm going to try and speed this up as much as I can. I hate to be a little bit rude, but I want to get everyone introduced, but then get to our stunning panelist.
Okay, Dr. Bambi W. Goddess.
Unmute, Bambi.
Okay. Am I unmuted?
Yes.
Yes, you are.
Okay, good afternoon. Dr. Bambi Gaddis. I'm CEO of the South Carolina HIV Council, doing business as the Right Wellness Center. 26 years old, also collaborating with a series of opiate treatment centers, integrating HIV, Hep C, COVID testing now. And we'll talk later.
Okay.
All right, Elizabeth Shahan.
Hi, everyone. My name is Elizabeth Shahan. I'm the Executive Director of West Virginia Prevention Solutions. We are one of 6 prevention lead organizations in the state of West Virginia. We focus on substance abuse prevention and the consequences of those. And we cover 13 counties in North Central West Virginia. And I'm appreciative and thankful that I'm still working, even though from home. And I'm thankful that we are actually becoming more effective in our outreach to schools, community groups, coalitions across the state, even during this pandemic. And that is amazing. We're reaching more students with social emotional learning skills. And I didn't expect that, so I'm thankful for it.
Thank you so much, Elizabeth. Okay, next we have Jeremy Spear.
Hello, I'm Jeremy Spear. I work for WVU Health Science Center here in Eastern Division in Martinsburg. And I work on our state opioid response grant for Berkeley and Jefferson County, and I'm the stigma reduction coordinator on that grant.
Thank you so much. Okay, next we have Johnny Kiefer.
Hi, I'm Johnny Kiefer. I work with Elizabeth Shahan in Region 4 for West Virginia Prevention Solutions. We do substance use prevention, like she said. I'm grateful for being close to nature and having the opportunity to grow my own garden and help share that, with my neighbors and people in the community.
Thank you so much. Next, we have, I believe, Kara Greathouse.
Hi, I put this into the chat, but I'm Kara Greathouse. I'm the Planning Director with the Regional Intergovernmental Council in Charleston, West Virginia. We're a planning and development council, but I mainly handle all things transportation. And today I'm grateful for my morning run.
Thank you so much. Okay, so I've gone back up through those. Laura Jones.
Hello, I'm Laura Jones. I'm the Executive Director at Milan Pushkar Health Right, a free clinic in Morgantown, West Virginia. And we are very much focused on harm reduction and Hep C and HIV prevention among that population. And we also celebrated our 5th anniversary of harm reduction services last week. So I'm grateful for that very much so.
Thank you so much, Laura, and thank you for all you do here in Morgantown. Okay, and our next guest is Linda Villarosa.
Hi, everyone. I'm Linda, and I'm calling in from Brooklyn, New York. I think I'm the only outlier here. I am a FOT, friend of Tony, a journalist with the New York Times Magazine, and I'm writing a book about race, health, and inequality. So trying to understand more about rural health and make sure that I cover that well. So I'm really interested in the work you're doing and honored to be on this call.
Thank you so much, Ms. Villarosa. Next, we have Lynn O'Connell.
Hi, I'm Lynn O'Connell, and I'm the Associate Director of Addiction Sciences at Marshall Health in Huntington, West Virginia. And I am grateful for my 2 Wheaton Terriers who have been my work from home companions.
Thank you. Luann Kramer.
Hi, I'm Luann Kramer. I'm with the Jefferson Berkeley Alliance on Substance Abuse Prevention, a grant-funded coalition. It's good to be here. Thank you for the invite.
All right. Malcolm Lanham.
Yes, my name is Malcolm Lanham, and I am the Population Health Director for the Mid-Ohio Valley Health Department here in Parkersburg. I manage, I think it's 5 QRTs in our area, and I also manage the Regional Threat Preparedness Unit as well. And something I'm grateful for is always my family, but I'll be done with paramedic class soon.
Excellent. Thank you so much. Okay. After Malcolm, we have Renee DeLong.
Good afternoon. I'm Renee DeLong. I'm the director for the Jackson County Family Resource Network, and I'm also a member of the Jackson County Anti-Drug Coalition. And I'm just happy to be here and interested to see what everybody has to share this afternoon.
Thank you so much. Maria del Rosario. Maria. All right. So next we have, sorry, give me just a moment. Suzanne Wilson. Suzanne?
many more do you have, Marcus?
Several.
All right. Well, how about this? Well, I'm sorry to do this, but I'm gonna have to cut off introductions because we're already at the 27-minute mark. And I apologize for those who didn't get to introduce themselves, but if you could do that in the chat box, and at either the middle point or end point, we will roll into those introductions. I can't see the list. Marcus actually, I guess I could if I did the list of everybody who's on the call. And maybe Marcus, if you could tell people how to do that, how they can see who all has joined. Can they all see that?
I will figure that out.
Okay, thanks. So I'm going to go ahead and get this party started. Again, I want to thank each and every one of you for joining and taking time out. We got asked a couple of times, well, who is the audience? Who's all on this call? And we said to them that folks that had registered were representative of community-based organizations, local health departments, state officials, and they came from a diverse group of sectors. So the harm reduction sector, the substance use disorder sector, HIV, Hep C, hepatitis overall, but also just that these were folks that were strategically engaged in community. And what we wanted to do is that we wanted to host this call in part to talk about the 3 areas that CEG is working, which are HIV awareness and access, the opioid treatment moratorium, increasing access to methadone for clients and patients, but also the elimination of viral hepatitis in West Virginia. And we wanted to talk about what we're doing, but we also wanted to learn about what it is that you are doing, how we want to be able to move forward with you in partnership, but also how we want you to be able to call on us if you needed us as well. And so let's go to the first slide, Marcus. Thanks. So here are the things that we know about substance use disorder in West Virginia. And for those of you that live here, I'm telling you a tale that you already know. And that what we have seen is that substance use disorder, HIV, and viral hepatitis have been in these 3 silos. And usually the harm reduction people are not talking to the substance use disorder people, the Hep C people or the viral hepatitis people aren't talking to the HIV people. And what we really think is that we've got to be able to work together. You know, the National AIDS Strategy has a quote in it which says that none of us can do it alone. Not funders, not community-based organizations, not local government, state government, or federal government. That we all have to work collaboratively to do this. So one of the things is that we really want to do is figure out how we create this partnership and work in collaboration. Like we know that the state is planning a work group on viral hepatitis, on hepatitis elimination. But we also know that we need to be developing a plan for ending the HIV epidemic, which is going to be, West Virginia will be in phase 2 of that plan. And how are we kind of putting these things in sync? And then also, what are some of the solutions? So when it comes to solutions, we looked at the opioid crisis in the state and thought it was a bit strange that there was a moratorium on providing or the utilization of methadone, which started in 2007. So we said, well, let's work to see if we can overturn that. And we've gotten some really great support from the Governor's Council on Substance Use Disorder. We've gotten some great support from colleagues like you, and we'll probably be reaching back out to you at some other point for a sign-on letter. It's things like that that we think that we can do to increase access and increase the capacity But we also know that there are other things that are out there around elimination of viral hepatitis. And that's why we invited folks from the National Viral Hepatitis Roundtable to talk to us about existing tools. Where have other people been successful at the state level of working with community and states to be able to eliminate viral hepatitis? And while we have a few folks on here to talk about substance use disorder. Marcus, can you go to the next slide, please? So right now, West Virginia's HIV epidemic continues to be driven by substance use disorder. We know that our hepatitis crisis, which is Hep C, Hep B, Hep A, are also issues that are severely impacted by substance use disorder. As you can see by the slide, 62.3% of all new HIV infections in West Virginia are listed as injection drug users as their primary risk factor. West Virginia's Hep C testing statute, which really kind of limits an individual organization's or institution's understanding of who can conduct rapid testing in the state, has been a bit challenging. So we are actually working with the state to put out a new tool so organizations, health departments will know how to conduct rapid testing if they want to. Everything from how you get your CLIA waiver, how you get your federal CLIA waiver, to how you can get rapid testing training in your state. What partners at the national level can you work with a pharmaceutical company to come in and do your training? Can you work with a manufacturer, the OraSure, or another partner that makes the technology to do rapid testing to come in and do your rapid testing? So that's what we want to do, is that we want to expand the number of partners that are doing rapid testing in the state. Next slide, please. Thanks. So here's a brief overview of the Ending the Epidemic strategy, and I'm going to let Anna talk about the Ending the Epidemic plan and what that means and what that means for the state. Anna, to you.
Hi, everyone. So I'm just going to do a very brief overview of EHE. So just so we are all on the same page. So last year in 2019, the Trump administration came out with this plan with the goal to reduce HIV infections by 75% in 5 years and 90% in 10 years. So phase 1 was focusing on 48 jurisdictions and 7 states, majority of them in the South, and you can see in the map down there. So then phase 2, like Tony was saying, will add a broader range of jurisdictions, which includes West Virginia. So then there are 4 pillars for the EHE, which is diagnose, treat, prevent, and respond. So like responding to outbreaks and whatnot. And all the funding from the EHE was divided into the CDC, HRSA, NIH, and IHS. And now we're seeing like how COVID is impacting phase 1 of the EHE. There's a lot of things that haven't been implemented yet. There are some concerns about how phase 2 will roll out. So these are things to keep in mind to see if this goal that they set out will actually be met in the timeline. I think that's a very brief overview of the EHE. I'm not sure if I should go more in depth into it, but I know we're short on time.
Well, I mean, I think that that's a good overview. I think that anybody who doesn't know about the Ending the Epidemic plan, we'd be happy to send you more materials, and that's what we'll do as a follow-up to the call. I think this Ending the Epidemic plan is central to West Virginia, because West Virginia, as you can see on the map, is not one of the jurisdictions that's highlighted in blue. West Virginia is what's considered a phase 2 jurisdiction, which means that we should be in our planning phase or getting ready for our planning phase. I think that what we really want to be able to do with people on this call and people in your networks is to begin to have a conversation with DHHR in West Virginia about putting together a community body that is responsive to the Ending the Epidemic plan. Each jurisdiction is required to have a community-driven plan. And I think we want to make sure that as many voices, as many diverse voices are involved in developing that plan. And I kind of want to put a little pin here and say that our mantra or our position is that we want to do whatever we can do organizationally and community-wide to support the health department in doing its job and doing its job better. This is to say, we want you to also be involved in asking the question of what's going on with the state's Ending the Epidemic plan, what's going on with the state's viral hepatitis plan, and getting involved. I think we all know that the state is overwhelmed right now with COVID, and that is its focus and its priority, but these other things are still happening at the same time. And we want to be able to support them in doing this right and well. So next slide. So viral hepatitis in West Virginia. West Virginia continues to lead the nation in new viral hepatitis infections. Surveillance reports from the state have not been updated for the past 2 years. Barriers are particularly for vaccination for Hep B. Testing and treatment continue to plague West Virginia. One of the challenges we know is that all of the MAT, medically assisted treatment providers in the state, are required to screen for HIV and for Hep C. And what we want to make sure that we're doing is putting in place a plan that increases access for those people to get to treatment, care, and hopefully cure. And so we know that that's a part of one of the strategies that we want to put into place. And so what I'm going to ask Adrian to talk about kind of what Hawaii has done. And then maybe if Nicole and Michael, he's got a second name that I just forgot, will also join in on a discussion of what's happening around the country and what are other states doing with their viral hepatitis elimination strategies.
Sure thing. Thanks, Tony. I appreciate that. For the sake of time, I had a couple of slides that had a map, but for the sake of time, I won't share them. I'll be sure to pass them along to Tony and Marcus for distribution to the group after the call. But really what I just wanted to say was, this is certainly viral hepatitis elimination planning is certainly a topic of interest to a number of states across the country. We certainly have seen a number of elimination projects that have happened over the last number of years. But what we're really starting to see, and it came about as a result of the World Health Organization really charging nations to eliminate hepatitis, knowing that there's a cure for hepatitis C, to eliminate hepatitis by 2030. And so what we've seen is that a number of states have taken the initiative to develop these very thoughtful and comprehensive elimination plans that is a culmination of partnerships across their communities and across the state. And so whether that's partnering with state and local health departments, community-based organizations, certainly there's also a component of appropriations and funding that needs to be dedicated to these plans for them to be successful, partnering with harm reduction organizations. It's really this well thought out plan about how an individual state is going to go about attacking hepatitis for their community. And so the HHS actually maintains a map on their website that kind of maps out all of the elimination projects. And so what you'll notice is that when you see the slides is that there are a number of states that are colored because they have some form of an elimination project, including West Virginia. West Virginia is actually highlighted due to the funding that they received through the HepConnect project. But there's a key difference between an elimination project and an elimination plan. So there's only actually a handful of states that have these comprehensive plans. A couple that come to mind, Tony mentioned Hawaii. That's the most recent state to announce their elimination plan. Washington State and Louisiana also have elimination plans. And then New York State as well as Florida, just to name a few. And so when you look at that map, I just wanted to point out that there is a key distinction between a state having a comprehensive plan versus some sort of elimination initiative or effort in their state. And so NVHR is happy to work with folks and connect you to folks in other states, again, as a national coalition. If you'd like to learn more about how to form those working groups and what is needed to be successful, we're happy to help facilitate some of those conversations. So I will put my email in the chat. Feel free to reach out to me. And again, I'm happy to connect you to anyone that might be helpful.
Thanks. Nicole and Mike?
This is Mike. I can give a quick update a little bit more on hepatitis, and then Nicole will give an update for HIV. Just really echoing everything that Adrian said as it relates to hepatitis elimination plan. We have been in discussions with our members as it pertains to making sure that community is engaged throughout the entire process, both during the drafting of it, the reviewing of it, and getting the finalized product out the door. The only other thing that I would highlight is that some jurisdictions are looking at it as an integrated approach. And so some jurisdictions, for example, like Tennessee, had integrated their HEP elimination plan with also HIV and STDs. And so that is something that has been happening within some jurisdictions in looking at how they can be integrated. And with that, I'm happy to hand it over to Nicole, and she'll provide a little bit more around some of our actions as it pertains to HIV planning.
Thanks, Mike. Yeah, so community engagement is so critical in having an effective plan, whether that's to end HIV, the HIV epidemic or viral hepatitis. NASTA has been working really closely with our members as well as the different phase 1 jurisdictions on ensuring that they are effectively engaging community. We've done a series of webinars on effective community engagement strategies. And I think it's really critical that you all are starting this process now because these voices need to be centered in these plans that are developed. NASTA does provide capacity building assistance on community engagement strategies, and I'll put my email in the chat. We also have a map as well that highlights different jurisdictions and the plans that they've created. Not all of them are necessarily end the epidemic related though. So I'll also put the link to the map in the chat as well for you all to look at, as so many jurisdictions are doing really creative, integrated processes to end their HIV epidemic. And just in general, I think when thinking about these plans, we really need to think about meaningful involvement of people living with HIV, meaningful involvement of people living with hepatitis, because without them, we won't be able to actually end these epidemics.
Thank you, thank you, thank you all. So we've gotten a few questions, and before I lose many of you, I wanna kind of get through some of these questions. One question is there progress on decriminalization and a shift in emphasis on treatment? That's from Chess. Chess, can you say a little bit more about that question? If you're still here. Marcus, can you just unmute? Yeah.
Gotcha. My concern is that patients with hepatitis C seem to be delayed a long time to get their treatment. You know, they say you've got to have some real disease there. And I don't see a reason why they can't be treated as soon as you know about it.
Well, so Chess, two things. One is that we know what we're working on right now, policy-wise with the state, is to eliminate the double PCR test that is required. That's what we think is one barrier to access to Hep C treatment. So that's one thing. And I think that the criminalization piece is that what we see that as is the sobriety requirement around treatment. The fibrosis score has been reduced, but we think that it can be eliminated. And again, I think that some of the folks on the phone might be able to talk about what other jurisdictions have done. And those are some of the models that we are certainly looking at as following, and working in collaboration with Medicaid and Medicare in the state to say there isn't an additional cost burden. There will not be this rush on Medicaid for these treatments.
Well, thanks a lot.
I'm happy to jump in here as well, Tony. So yeah, NVHR does a lot of work around treatment access advocacy as well as a number of our partners that are on the phone from Gilead. And really, you know, the three main things that we've been focused on from an NVHR perspective is how our Medicaid beneficiaries are accessing treatment as it relates to prioritization criteria. So I'm sure many of you on the call know that prioritizations continue to pose a barrier to treatment for a lot of folks. And the three main things that we've been focused on is the requirement of having severe liver disease to access treatment, the requirement to be abstinent for a certain amount of time to access treatment, and then the third thing is the specialist requirement. So where states requiring a patient to be referred to a hepatologist or an infectious disease specialist in order to access Hep C treatment. And so those are kind of, that's a big focus of NVHR's work, and certainly there's still a lot of work to be done in West Virginia. Tony mentioned that there's now this requirement of having 2 viral loads before a PA can be approved through Medicaid. And so we're working along with the community education group to increase advocacy efforts around that as well. But certainly feel free at any time to reach out to me or anyone, or to Tony, and she can get you connected with me. If there are things that you're seeing in practice, any barriers that we can help remove. We often are attending Medicaid meetings, and we have a large provider and patient advocacy network that's been really effective in other states. So please feel free to reach out.
Right. And Chess, you had another question about cost. So hang on, Marcus, we'll do that later. But you had another question about the cost of Harvoni. What was your question? Because it's been deleted from my box.
The simple question is, it's available at a very low cost elsewhere in the world, and insurance seems to delay treatment because of the cost. And you know, that's the basic problem. And as we're delaying treatment, the patients are spreading it to other people.
And so I think that, and I don't know if they can speak to it, but I know that we have some folks, some reps from Gilead who may be on the call. But I think that one of the things that I think Gilead has done is instituted patient assistance programs that have helped to augment cost in some jurisdictions. I think one of the challenge, and I'll let, if I don't know if the folks from Gilead want to talk about this or not, about access. Yeah, Trina, can you speak to this?
Excuse me, would that apply to Medicaid and Medicare patients?
Well, that's just it, right? So the challenge often that we find in the state with Medicaid and Medicare patients is that the barrier is the physician and the physician having access to the things like putting in place the barrier of the double PCR test, and then having the substance use disorder requirement, and then it's like and then. So we have to increase provider knowledge of how to even either get the patient on a patient assistance program or get the patient the secondary Medicaid application. Does somebody from Gilead want to talk about the patient assistance program for hepatitis C or no?
One of the things that I'll just add in relation to the Medicaid and Medicare question is that certainly the cost of therapy has come down significantly over the last couple of years. And what we're seeing in some other states, in thinking about Washington State and Louisiana State, both actually partnered with pharmaceutical companies in order to access a large quantity of medication for a reduced price. And so that's something that states are thinking about in their elimination efforts. Are there kind of these innovative models that they can use to bring down the cost of drugs even further? Some other things that we've seen in various states around our advocacy and treatment access is, are there preferred agents, for instance, that can be recommended? So again, the more that you buy of something, typically the cheaper it will be. And so that's another kind of prioritization criteria that you'll frequently see in other states as well, is them steering you towards preferred drugs in order to bring the cost of that treatment down.
Thanks. And Chess, I got a note from Trina Scott of Gilead, who says that she is actually on the HIV side of the house, but will put you in contact with the Hep C rep, who could probably answer more detailed questions for you.
Thank you, Tony. Hey, yeah, this is Trina here. I'm also going to put the link to our Gilead's Advancing Access program that can give some more detailed information to your question. And just know that, you know, this program is really committed to helping patients afford the medication, no matter what the situation is. So if you have any more detailed questions, my information is in the chat box. Thank you for the opportunity.
No problem. Chess, does that help you out?
Thank you. That's great.
All right, perfect. All right, and now I've got a question from Doug Anderson. Can you provide more information on the surveillance reports for VR? Or who submits local, county, state links, examples? Who typically works this in the local community? Did I get that right, Doug?
Yes.
Marcus, can you answer that? Because that's like your wheelhouse.
Absolutely. So every year, usually every year, the state of West Virginia Department of Epidemiology, Office of Epidemiology and Prevention Services, puts out surveillance reports for HIV and viral hepatitis. The last viral hepatitis report that went out was the 2016 report, which was released in 2018. And this data is gathered by collecting surveillance from each county and from the various reporting physicians, hospitals, and other people who test for viral hepatitis. And they gathered this information and then submit it to the CDC for finalization. However, at the state level, what we continue to see is that, at least from the Office of Epidemiology and Prevention Services, there has been a considerable lag in putting out these reports, particularly around both viral hepatitis and HIV. This is troublesome because West Virginia continues to have the highest rates of viral hepatitis in the country. And if you're looking at the most recent CDC report, one of the things that we're seeing is that around 68% of transmission across viral hepatitis occurs as a result of injection drug use. Now, this is something that we really have to increase surveillance on, not just at the state level, but at the local and county levels. And the way that we do this is by expanding testing outside of traditional facilities. So, you know, it's not enough that the health department is doing screening for HIV and viral hepatitis. We have to get community-based organizations, free clinics, primary care providers to provide these kinds of testing services so that we can reach patients who are typically hard to reach, hard to test, and hard to treat. Once we have this surveillance data, we will be better positioned to create the kinds of statewide elimination plans that we need in order to help West Virginians, you know, live happier and healthy lives. So I think to kind of sum this all up in one big package, you know, one of the things that's very concerning is that, particularly around viral hepatitis, when COVID-19 hit, testing has essentially continued, but it has not continued at the normal rate that it was, which was already considerably low. So our concern here at CEG is that once we return to some sort of normalcy, we are expecting a pretty vast increase in the number of newly identified cases of HIV, hepatitis A, hepatitis B, and hepatitis C. And we need to start formulating plans to confront that now, so that we are able to deal with that when we do resume normal testing.
Thank you, Marcus. So, you know, I think that that's a bit of what kind of how we got here with this call is, you know, everyone is stretched so thin already. Are there ways in which we can work together collaboratively with the state, with local and county health departments, with community-based organizations to not just put in place an elimination plan, but also to put in place some elimination structures and some implementation ideas. Like, you know, I think that we know how big this problem is, you know, and Henry Masur, who is in charge of Hep C for the National Institutes of Health, said to me once, he said, you know, the problem in West Virginia is so big that it's going to take tens of millions of dollars to get to a place of hepatitis elimination. But I guess my core belief is that if we don't start somewhere, we'll never get there. And I'm really and truthfully hopeful that we can do it together. You know, CEG can't do it alone. None of the organizations on the phone can do it alone. None of the health departments can do it alone. But I just really feel like if we start to work together to address these problems and come up with strategies that we're doing together, like, is it that we should, given the limited bandwidth, put together the ending the epidemic part with the Hep C part so that people have fewer meetings that they have to go to, but can address both of these very, very huge issues. With harm reduction, can we make sure that we're getting harm reduction services in broader communities? But we now need to educate providers and community on what harm reduction is and what it isn't. You know, I think that the end, what I hope to achieve, which many have asked about this call, is that maybe we even have some little statewide work groups that are working on issues like Chess is really clearly into, you know, Hep C and from provider perspective and access. Should we have like a statewide Hep C provider access or Hep C elimination work group that's independent of the state, but that we could go to the state and say, we all came together, here's what we want, and here's what we would like to do with you, for you, as a part of you as well. That's what I'm really kind of coming away from this call with, is maybe we have to establish our own work groups and take the information to the state and have it be a relationship where we're working together to eliminate some of these things. I know some of you on the call have probably been invited to be on some of these work groups, but we need to make sure that it's more community voices that are being heard, not fewer.
Tony?
Yes.
This is Bambi Gaddis.
Hi, Bambi.
I'm hearing two things. First of all, you're discussing the building infrastructure to address integrated testing. And so I think there's some lessons learned from other states. I know we have a hepatitis, viral hepatitis work group. I think there's some opportunities to interface with some states that are southern or that are serving rural and what I'll call urban, suburban communities. The second is organizationally. So when I think of the road that our agency took and as a focus, back to Gilead, as a focused recipient, providing hepatitis C services to our communities through our mobile unit, as well as through our community outreach and in-house services. Just a lot of what we learned in that process. And now that we've integrated COVID testing, I mean, I don't think we can remediate or not consider integrating some of those testing opportunities within this HIV viral hepatitis landscape, because they're all, and STDs. Let me just add that to the formulary. So I know that as a community-based organization, I know I certainly would be willing to talk with you offline or to a group offline about things that we've learned in our journey. I don't know how you want to follow up with that, but I'll leave that in your queue. But I think there's other folks like Right Wellness Center who have some lessons that we'd be more than willing to share as you all continue to move forward in your strategic plan.
Thank you, Bambi. I really appreciate that. And do other people have questions before I kind of go on to the next thing? If you have a question, feel free to either unmute yourself or put it in the box. But we've also gotten another note from Gilead about HIV therapeutics and treatment from Tanya. And Tanya, I don't want to butcher your last name because I was going to say Bugard, but I may be very wrong in that. She's an HIV therapeutic specialist from Gilead covering Maryland and West Virginia. She's put her telephone number and email address in the chat box. Now, here's one of those things I'm going to say that people may or may not know. And if I'm talking to you like you're crazy, I apologize. So one of the values of Trina and Tanya here is that these are individuals from Gilead Sciences who can come in for you and do a training for you, can provide what I think that they refer to them as on brand and off brand. So if you have a Hep C, you want to do a group for your clients or your patients to learn about Hep C medication or HIV medication, they can come in and do a tutorial for you. They also have access to a group of medical scientists that can come in if you want to do it with a provider group. And I think that there are ways in which you can leverage the resources of a Gilead to definitely increase access to treatment, but also to do localized educational opportunities. And folks from Gilead, if I have framed that completely wrong, please tell me offline. No, just kidding. please correct me right now.
That was wonderful, Tony. Thank you so much for that. And we would love to do some more in-person or virtual educations within the state of West Virginia.
Thank you. So, either Tanya or Trina, can you give people a couple of examples of the types of trainings or opportunities or learning experiences they can have with Gilead?
Tanya, you want to go ahead and do your brand?
I will. So, hi everybody. This is Tanya. It's Bogart. It's way easier than it looks.
Okay.
Add in all the vowels and it confuses everybody. But I am on the HIV side. So we have branded and unbranded programs. We have programs with HIV and aging. We have ending the epidemic. We have resistance. We have so many different programs that are able to be done virtually as well. Trina, our community liaison, also has patient advocacy support group programs, different things like that. And we have really a million different resources that we can help out with, whether it's patient assistance or just education resources for your staff, for your patients. Just reach out, and if Trina or I don't cover your area, we will put you in touch with the right rep. And we cover, you know, hepatitis, HIV prevention. So we can definitely connect you any which way that is needed. And I think a lot of you know Kathy Tobin on the line. We work very closely with her, and hopefully she'll shout out our praises for you as well.
Cool.
But
Kathy,
pleasure
thanks. Thank you very much. Thank you very much, Tanya. Kathy, can you maybe talk a little bit about what you're doing with patient engagement or outreach or what have you?
Hey, this is Kathy Tobin. Can you guys hear me?
Yep.
All right. Yeah, we are located in Martinsburg at the Shenandoah Community Health Center.
Uh-oh, you muted. I don't know why you muted.
Am I good? Okay.
Yep, there you go.
All right. So we have had a program here for the past, since 2004, actually 16 years, but the past 10 years Part A funded. So we work closely, but ours is you already have to be HIV positive for round white funding, so there's not a lot of prevention or front end testing. But I mean, we would definitely be willing to work after a positive diagnosis is when we step in and help out the most. As you can see, most of our co-infected patients have been treated and cured. We work closely with Dr. Simmons and getting treatment, and with Trina and Tanya. They're amazing at getting patients that are denied therapies for HIV and Hep C. Whatever we need, they'll get, use the advancing access to get us medication.
Okay, cool beans. Chess, do you know Catherine?
It's been a little while, but yeah. No,
all right.
Sorry.
Okay, so I definitely want to, I definitely want to put you together. Hang on, I got another question in the chat box, and I know it's late. And, oh, look at that. We've got a medical scientist. His name is Jarrett Coffey. And Mr. Coffey, if you're on the line, if you could give a few words about what medical scientists can do.
Absolutely. So you framed that very well earlier. And really, if you want education and scientific exchange of data for your providers, we are definitely, that's what I'm here for. I cover HIV prevention. So really any question that you have that your great reps may not be able to answer, as it could be off-label, then that's where I come in to help support you. I have some branded decks, but really we have a lot of unbranded decks that we can use for implementation, differentiation between the products. So definitely here to support you.
Cool beans. So, I know we've been on now for about an hour and 10 minutes. And this is I told her I described this as our first date. And like I said before, what I wanted to do is to get us all together, to hear what people are doing across the state and around the state, and how we can be supportive. So what I would like to use the last few minutes that we are together for is, are there, so Marcus is putting up our COVID-19 packets. We were, as of Friday, we closed it out on Friday. We're going to be getting out over 2,000 COVID packs. Those are backpacks with mask in them, hand sanitizer in it, and a gift card to purchase water. It looks like Marcus said that there are 360 packs remaining that are available. If you want to get one of those 360, Amanda Morgan is your person, and she'll kill us all later for having just put her email there, but that's okay. What a way to go. So that's that. So, but what I'd like to do is open it up and ask if anyone, first of all, if anyone has just an urgent need, right? Like, what do you need right away? I'll ask the ending. We'll do a little survey too. Were you aware of the Ending the HIV Epidemic plan? Did you even know that the HHS or the administration had called for this plan? And so I think that's question one. And then question two, did you know that West Virginia was in phase 2? So if you could take a few minutes and answer that while thinking about if you have an urgent need right now, that I need training, I need awareness, I need to figure out how to integrate Hep C into my HIV or into my community health program. Does anyone have a need right now for partnership, for working together?
You only talking about West Virginia?
I'm talking about West Virginia, not South Carolina.
Oh, okay. Because I was going, well, let me put my need out there anyway, and then that might reflect on someone else. I need rapid COVID testing.
Rapid COVID testing.
You know, you can go into COVID testing, but eventually, given the response from the community and this intersection of people who never come in for HIV, but will definitely are showing up for COVID, we need a rapid test. We need resources for rapid testing.
Okay. Anybody from West Virginia? So, okay, then let me ask my next question, which is, would people be open to having a monthly call where maybe we break it up into work groups around either Hep C or elimination strategies or testing strategies or criminalization or access? We would figure out how to break it up into some distinct groups and have some sort of action plans, letter writing, or getting DHHR on the phone to hear kind of where people are in community. Would people be open to a monthly call?
This is Doug Anderson. Yes, I would be open to a monthly call, but I have a specific request that might help make those meetings more effective. Is who's out there that represents everything that you've talked about here in the local area? Who are the agencies? Who are the points of contact? I am amazed, as the chairman of the health work group, how many people I run into that say, yeah, I do this and I do that, so on and so forth. So if there's a list out there, or you know of folks, or you cobble together a list, that would be most helpful.
We are putting, that is Amanda who is on here, we are actually putting together a statewide resource directory because we're with you. We were trying to figure out who was out there too. So that is definitely one of the projects that we are implementing right now.
Yeah. Okay, great. I think Amanda is on our health work group. In fact, she has sent me information to release in our messages that go out to about 500 folks or so in the three counties plus some statewide organizations. So part of this is uncovering who's doing what, connecting the dots, doing coordination and collaboration. I'm just amazed at what's out there and amazed at the capabilities that are out there. But if we're not connected together as a group, then the patients, the clients, they get lost, or there's opportunities that I've seen organizations miss out on.
I completely agree. And again, our thinking is that across the state, whether it's regional or county by county, like if you are dealing with an individual who is impacted by hepatitis, you may likely be reaching that same person in a substance use disorder, and you might reach that person in HIV. So that's what we want to put together, some kind of continuum of care across the state. Anyone else? And I'm sorry our first date was so fluid and not as guided and directed and as outcome based as I hope our future meetings would be. But again, I think this is the first time that I can recall of us coming together across the state like this on our own volition, not being brought together by state officials. So what we will do is that we will put out another email, and what we might do is do different meetings for different topics on different days once a month. And if you're interested in one or the other, you know, we will go ahead and have that meeting instead of having everybody come together for one. But I kind of think I'd like to keep us all together because, again, as I said, I think that there's so much of our work that is inter and intra related. And it looks like most people are up for a monthly call, so that would be cool. Again, I want to thank you all. It's been about an hour and 17 minutes that we've been on this call together. And so again, I want to thank you all for taking time out of what I know are hectic schedules. We will send you notes from this meeting along with information on how to reach the folks at Gilead thank you for joining the call. I didn't know y'all were going to be on, but I'm happy that you were. And what we'll also do is send you links to the statewide opioid moratorium survey that we're doing, as well as a survey for the Rural Health Service Providers Network that we're doing. So again, thank you very much. And I hope everyone has an amazing day. And thank you for all that you do for the state of West Virginia.
Also, one more thing before we go. This session was recorded, so we will have that recording available on our YouTube channel as soon as this meeting is over and we get it edited.
Thanks, everybody. Thanks, Marcus. Thanks, Amanda.